Good morning, everyone. Welcome to Urogynecology for Beginners.
I'm Dr. Diksha Pandey.
I'm Dr. Pranadeep.
So, what is the update, Prandeep? You said you wanted to give me
Yes,
some
ma'am.
update.
This is regarding Urogynecology Fellowship, ma'am.
Okay.
And so far, we have more than 10 applications since last week. And many of
Oh, you
our.
have started the submissions only opened the application only last week, I think.
Yes, ma'am. We opened the form
Okay, that's
from.
good.
Yes, ma'am. And the thing many of our interested candidates or applicants they are asking me was what is the length of this course? And I want to tell again, we have already told, and it is 12 months course. And one more question many of them are asking is are there any short-term courses like for 3-4 months, or some people are asking for 1 or 2 months. Sadly, I want to tell them that there are no courses we are running short-term courses. This is the one
Now.
as of now, and the only course is this is a fellowship program.
So, hope they are not messaging you too much and calling you too
no,
much.
no.
That day you were all the time you're saying this is fellowship message, this is fellowship message.
Yeah,
So, but you are handling it well, Prandeep.
Yes.
And then after this update, I want to ask you, you were saying something that on during rounds you asked some questions to PGs.
Yes.
What was that story?
Actually, many of our PGs who are now exam going batch, they don't know what is native tissue repair, ma'am. I don't know, somehow I feel that we should, even many of our viewers, there might be students who are writing exam like maybe near future. So for the benefit of them, can you just tell about native tissue repair?
Okay. So native tissue repair, this feels bad that my PGs are not able to answer when you ask them question during rounds. And this is one very much probable question which can come in basic sciences, which can come in gynecology paper, as well as which can come in recent advances also. This, I think the exam going PGs must know what native tissue repair is, what it means, what are the indications, what are the steps of it. And not just for the students, the people who are doing vaginal surgeries or who are into urogynecological practice. If somebody asks you, there is nothing great in that, but when somebody asks you, you should be able to answer, and you should be able to understand if that context people are talking about. So let's do one thing, Prandeep. I had some slides. I'll do a video on that. We'll do a narration and a slide. We'll put a video for that.
Watch this video on native tissue repair, and for further updates regarding the fellowship, just please follow.
Stay tuned for further updates if you want. So for now, we are going to show you a lecture series on native tissue repair. In recent times, if you have read about the management of prolapse, I'm sure you would have come across this term, native tissue repair. What is native tissue repair? It is the standard of care for prolapse management as of today. To simplify it, understand that the management of POP in last few decades have come across one round circle. Let's start the story from the quote of the famous Thielens. He wrote, "Every honest surgeon of extensive and long experience will have to admit that he is not entirely and absolutely satisfied with the long-term results of all his operations for prolapse." It is just hitting the nail on the head. So rightly put. And why are we not satisfied with the long-term results? The reason is simple, because the risk of recurrence is extremely high as up to 40%. So how to deal with it? Meshes for prolapse came into market with this idea only to reduce the risk of recurrence. Somewhere between late 90s and 2000, these meshes were introduced into clinical practice for the management of prolapse. The main idea was to reduce the risk of recurrence. However, this mesh, which was looking like a magical cure for prolapse, couldn't last long. In 2011, it was banned by the FDA because of related complications. And we had no other option but to return back to the basics. So today we have reached the same point actually from where we started. Decades ago, the management of prolapse meant repairing and reinforcing. It was more like an art which was passed from one generation to the next. Then came the vaginal mesh to reduce the risk of recurrence, but soon it was got into controversy to the extent that it was banned. So, what option are we left with? Again, back to square one: repair and reinforcement of patient's own ligaments and fascia. The only change is that we incorporated more scientific basis and evidence to it. But trust me, it is still an art. So native tissue repair is exactly what we were doing decades ago. Only the name is more sophisticated now. For anterior compartment cystocele repair, for posterior compartment rectocele repair and perineuraphy, maybe we have given more emphasis to the central compartment of apical suspension and enterocele repair now. Let's start with the anterior compartment repair of the cystocele. Till date, there is no consensus guidelines for cystocele repair. Everyone has his own technique. And this paper is an interesting qualitative analysis of these techniques in the United Kingdom. It is called VAST, Variation in Surgical Techniques Study. It was done across 21 centers in England and Scotland, where they tried to analyze native tissue repair practices for the anterior compartment and included infiltration, incision, dissection, facial repair, skin trimming, and skin closure. Making base of this paper, we will discuss all these steps of cystocele repair first, what the practices in UK are, then we'll tell you how, why, and what we exactly do when it comes to cystocele repair. First step in cystocele repair is infiltration. And out of 28 surgeons who were interviewed in this study, 3 said that they do not use any infiltration. 10 said that it is a superficial infiltration what they practice. 12 said it was deep, and 5 were actually not sure where exactly they were infiltrating, they were just infiltrating. We feel infiltration of vaginal tissues is a science. What we infiltrate? Cold diluted adrenaline, 1 ml of adrenaline mixed in 200 ml of cold saline. Why we do it? To reduce the bleeding and delineation of perfect planes. How we do it? With a thick bore needle for cystocele repair at an angle of 0 to 15 degrees, so that, as you can see it here, it reaches the correct plane while we are trying to lift off the vaginal mucosa from the underlying bladder. Second is the incision. In the VAST study, surgeons used various incisions, most longitudinal midline, some elliptical. There was a lot of discrepancy about where to start and where to end this incision. We prefer a midline or an inverted V, starting 4 cm from the external urethral meatus. That actually corresponds to the urethrovesical junction up till the lower margin if it is with hysterectomy. In isolated cystocele repair, 1.5 centimeters above the os, that is corresponding to the cervico-vaginal junction. For dissection, again there is no consensus. Some do superficial, some said deep. Some even suggested creating a separate facial flap of the pubocervical fascia. We strongly suggest raising a very thin flap of vagina so that most of the pubocervical fascia is retained for repair. I read it somewhere that creating a thin vaginal flap to retain maximum amount of tissue is becoming a lost art these days. I feel it is our duty that we must teach and insist this technique to our students. The lateral extent we go is up to the pubic rami until and unless we are planning for a paravaginal defect repair. Once it is dissected, how do you repair the fascia? In the line diagram, you can see various methods of native tissue approximation. We prefer either the box suture method or the purse string, depending on the size of the cystocele. Vaginal skin trimming or vaginal mucosa trimming was performed to some extent by nearly all surgeons. Most of them removed only a small amount of it. Some said that amount of skin trimmed was dependent on the amount of redundant skin or the size of the cystocele. What we teach is that if you are starting with a V-shaped incision, you have to remove those V flaps which you have raised. If you are giving a midline longitudinal incision, then you have to remove 2 triangles. Definitely it depends on the size of the cystocele and the redundant tissue, but yes, the most important point here is that you must keep in mind that when you are approximating this vaginal mucosa, it should be a tension-free closure. Next is the suspension or the apical suspension. And according to me, this step is where the magic happens, either in isolated repair or combined repairs. It is mostly done using the uterosacral ligaments, or else you can also do a sacrospinous ligament fixation. The benefits of this suspension is that it takes care also of the paravaginal defect to a certain extent. It takes 5 to 10 extra minutes, reduces the risk of recurrence, and length of vagina is well preserved or maintained. For the closure of entire vaginal incision, surgeons in the said study used vicryl of various sizes and all kinds of suturing techniques. We prefer continuous suturing with vicryl 2-0 with locking if required only for hemostasis. If the defect is in the central compartment, more important than hysterectomy is the apical suspension procedures, which are either sacrospinous ligament fixation or uterosacral ligament suspension. IUJ in 2016 published an interesting review article about native tissue repair for central compartment prolapse. They compared 2 techniques, uterosacral ligament suspension and sacrospinous ligament fixation. The important thing I liked about this review is its conclusion part. They very clearly said that apical compartment prolapse repair using native tissue with these 2 methods is not a compromise. This is a message for those who think that apical suspension can only be done with the help of abdominal sacrocolpopexy, which is a mesh repair. Without using any mesh, this article concludes that apical compartment prolapse repair using only the native tissue is definitely not a compromise. It gives a good functional outcome, a high success rate. Last one to discuss is the posterior compartment, where native tissue repair means rectocele repair and perineorrhaphy. Though traditionally called as posterior colpoperineorrhaphy in today's science, this term should be avoided, as we have understood now that it has to be a site-specific repair. Rectocele repair has a great advantage as compared to the cystocele, that you can put a finger in the rectum that helps delineate the specific defects in Denenvallier's fascia to guide an effective repair. Principles are almost the same. Dissect the flaps of posterior vaginal mucosa, repair the fascia, cut the redundant vagina if required, and suture it back. The steps in perineorrhaphy include a horizontal incision, minimal dissection, perineal muscle plication at the midline, and vertical closure of this incision. Important point that we have learned over the years is avoiding the levator plication, as was said mandatory earlier. Why? Because it increases dyspareunia and also leads to symptoms of obstructed defecation in some patients. In a nutshell, NTR or native tissue repair is the only available option for anterior and posterior defect as of today because we are not allowed to use vaginal meshes. Apical suspension make it as a rule of your surgery if you want to prevent recurrence. There is no standardization till date for the native tissue repair, so do it your way. But ask yourself why you are doing what you are doing. And very important is to follow up your patients and publish your results so that more and more scientific data and evidence can be created for future use. And at the last, it has been shown that a good native tissue repair gives a comparable 80.2% results as compared to transvaginal meshes, which was around 90% or 89.3%. So go for it. Native tissue repair or NTR is a science, an evidence-based science, which will give result. Though we must remember that every step of it is an art too. So learn it, teach it, and keep improvising.